Good afternoon, everyone. I am Brittany Newton with Georgia Health Information Technology Extension Center at Morehouse School of Medicine. I welcome you to today's webinar entitled Preparing for Meaningful Use Modified Stage 2, 2016. Are you ready? You can tweet us at Georgia-HITEC using hashtag Georgia-HITEC. Now, just to give you a little bit of background information, Georgia-HITEC is Georgia's only federal and state expert to assist providers in the achievement of meaningful use of EHR technology. Again, we are located at Morehouse School of Medicine's National Center for Primary Care. Before we get started, I just want to go over a couple of housekeeping rules. We're asking that all participants' microphones remain muted. If you would like to check your internet connection, it is in the right-hand corner next to the help sign. Also, you can refer all tech issues to tech support chat pod and refer all presenter questions to the presenter Q&A pod. There will be periodic stopping points for Q&A, and there will be time designated at the conclusion of the webinar for a question and answer as well. Now I will turn it over to our presenter today, who is Ms. Liz Hansen, a health information technology consultant who also serves as a meaningful use specialist to Georgia-HITEC. Liz?
Thank you very much and welcome everyone. I see some familiar names and I don't see your faces, but I do see some familiar folks on our participation list, so welcome to those. Good to see you again, and to those of you that have joined us today. So we're going to be talking about preparing for meaningful use, modified stage 2, and of course we're past the point of preparing. What we need to prepare for is to attest. So our objectives today are to provide an understanding of the requirements, and this is a part 2. So we will do a brief review of the pieces that we covered in our last webinar in this series. So we'll go over all of the modified stage 2 meaningful use requirements briefly. We will focus on the registry reporting requirements that we did not cover in our last session. And we'll also spend a few more minutes on the health information exchange requirements and how to meet this measure, because we do see that there is a lot of concern around this measure and practices in meeting this measure. So we will do a recap. We will provide some information on the summary of care requirement and the registry requirements. Just as a review, the EHR reporting periods for eligible professionals is for most participants a full calendar year still. I know most of you are hoping that we're going to get news that it's only going to be a 90-day reporting period for everyone, but right now it still is sitting at a 365 full calendar year reporting period, and we will certainly let you know if we hear of any change, but we have to continue forward as if that's what we're going to be having to report this year. If you're in your first year of meaningful use, then you would report on a continuous 90-day period between January 1 and December 31st of 2016. So the modified stage 2 objectives are to protect electronic health information, and I'm going to go over these a little bit more in more detail in just a minute, but we will look at clinical decision support, CPOE, e-prescribing, health information exchange, which has been an issue, and we will spend a little bit more time on that, patient-specific education, medication reconciliation, patient electronic access, view, download, and transmit, so that's a two-parter, secure electronic messaging, public health and clinical data registry reporting, which we will spend more time on today, and our clinical quality measures. So I'd like to stop right now before we go into any more detail and ask you to complete the poll. And Bridget, I'm not sure if I'm supposed to announce this or if you will. But we'd like to know which of these objectives you feel are the most challenging or giving you the most concern. So if you would just take a few seconds and complete this poll, we'd appreciate it. Okay, if we can end the poll, then we see that most of our concerns seem to be around number 5, which is health information exchange, number 8, which is your patient electronic access, number 9, which is your secure message to a patient, and number 10, which is your registry reporting. Now we will discuss number 5 and number 10 more fully in the session, but let's just take a few seconds and talk about number 2, number 4, and number 8 and 9. And please excuse me, I got to write these down because I won't remember them. 2, 4, 8, and 9. So this is a list of the same requirements, but gives you a little bit more detail. And it doesn't seem that anyone is having any concerns, or any particular concerns about at least half of these. I do want to say that for number 1, protect patient health information, as we emphasized in our last session, this is the requirement that you have a security risk assessment completed. It is to be completed before or during your attestation period within the calendar year. That's not so bad if you're looking at a 365-day calendar year, but if it's a 90-day reporting period, then we need to be flexible and make sure we've gotten this risk assessment completed. To do the risk assessment and have it acceptable, it needs to have a mitigation plan and dates around that mitigation plan. So again, if you have not done a security risk assessment, if you need some assistance from GA-HITEC, please let us know. But I can tell you that this has been probably the biggest reason folks have had issues with audits. So please, this is not as hard as it seems. Please don't leave this till the last minute. Let's go ahead and get that done, or get it on the calendar to get it done. And let us know if you need help with that. Your clinical decision support rules. Now this is a little bit more detailed, and a couple of you did have some issues with that. We did go into some detail in the last session. So if this is something that you need some specific help on, and you want to put your contact information in the chat box, then we can work to see if somebody with GA-HITEC can call you and see if we can help you out with your clinical decision support rules. How these are set up are specific to your EHR. So that's why we can't really address it effectively other than what the requirement is with a large group, because it is dependent on how you set these up within your EHRs. Some of you call them alerts. Some of your systems, they just call them your pop-up notifications. And the clinical decision support rules are something that we found a lot of providers don't particularly like have turned on, but you need to at least have them turned on during the reporting period so that you can say that you have them available and that they work. And these are decision support rules that pop up. For example, you might have one that pops up if it sees a female over 40. The alert would say, has she had a mammogram? It may be for a patient that has diabetes. The clinical decision support rule might pop up and say, have they had an A1C? So those are just 2 examples of clinical decision support rules. There are literally hundreds of them, but they do need to match at least 4 of your clinical quality measures. So the 2 that I named do match clinical quality measures, but this just may be a matter of us talking through what clinical quality measures you're using and what alerts we can have in the system to match those. And because we have a full year of reporting, for those of you that are in the 365-day range, we still have time to correct this and fix this and get this working. The next thing that some of you had some issues with was number 4, which is, was it e-prescribing? And that again would be something that we'd have to talk on offline. Some of you have had some issues with this tracking, but you're doing everything using e-prescribing, and we typically find that this is a formulary setting on your EHR. So again, most of our issues with this have been EHR specific, and we would be glad to help you with this individually if you'll let us know that you need some assistance. The next one that you wanted to take a look at, we are going to come back to HIE, is the view, download, and transmit. I think in the last session I told you about the patient engagement playbook. This is a document, a soft document. You can actually get it on a mobile device that the Office of the National Coordinator has developed that gives you tips on getting your patients involved and using their the patient portal, and for the requirement that a patient has to view, download, or transmit, this just has to be one patient. And so we do have some recommendations on how to take one patient over into an office and have them go ahead and access this just to get your one qualification. If you have some concerns or need some help with this one, please let us know. I think this is something we can pretty quickly give you some resolution on. If your problem is that your patient simply won't use the portal, so you're below 50% on that threshold, then the playbook may give you some recommendations, and we also have some recommendations that we can give you individually that might work for your practice and have been successful in other practices. If you'll just let us know who you are and that you need some assistance on this, then we can follow up. Everyone or most practices have an issue with getting their folks to use the patient portal, and I think we discussed some of these resolution methods in the last session, but we would be glad to give you the link for the playbook if you do not have that. And we will also be glad to work with you individually on some recommendations that will work for your office. In a couple of years, we're going to look back and say, okay, what was the big deal? But right now, we can get our patients, they're probably whizzes on how to use Amazon, but for some reason, we can't get them to access our patient portal. So we will have some additional, we do have some additional tips for that if you'd like some assistance on it. Number 9 is the secure messaging. Folks, this is just that you need to have one patient. You need to have your provider engage with one patient and send a message to one patient from the portal. And we'd like to recommend that you either have the patient send a message and the provider respond. You can take a screenshot of that response, or it should be in your tracking or audit report. But we do want to make sure that you understand that the provider needs to, the audit report needs to show that the provider responded. If this means that a mid-level is actually getting on into the system, someone else is doing the responses for them, then as long as the audit trail is showing that the provider's login responded, then that will be acceptable. Again, this is something else that we can help you out with on an individual basis. This is actually easier than you might think. This is one of the easiest requirements, and we do have some recommendations that we'll be glad to give you. We do want you to note that you have some yes/no questions, and on many of your systems, many of your systems don't show all of these yes/no questions on your meaningful use report. That doesn't mean they're not required. Many systems only show the quantifiable measures, such as number 3, 4, 5, 6, 7, and 8. So often your report doesn't show these other measures. These other measures are still required. So please take a look at these measures when you check off your checklist. Make sure you've got all of them covered, not just the ones that have quantities. If you've got a system that requires you to turn on the yes or no, and if you're doing them, then turn the yes on. This doesn't impact your attestation if you're doing something, but you need to print out a copy of that report, and in case you're audited in the future, up to 7 years, you have to retain that. And if you forgot to flip it to yes and you turn that report into the auditor, they're going to question it. So if your system requires that you answer yes or no, and you're doing this, you go ahead and put yes on there. If you answer no, you're not going to pass attestation. So you need to, and if you have a no on it for an audit, you're not going to pass an audit. So we want to make sure that we've got all these in sync, and that you have all the yeses turned on, and that you're hitting all of these thresholds. It isn't all or none. If you don't meet one of these thresholds and don't have an exemption, you answer no and don't have an exemption, some of these don't even have an exemption available, you will not pass the attestation. Now, the clinical quality measures are the same as last year. You have to pick 9 clinical quality measures that spread across 3 domains. There are 6 domains, so you just have to spread across 3 of them. And this can be, you could technically have 7 in one domain, 1 in another domain, 1 in a third domain, and that would qualify for this. The quality measures are also important to us because they help us determine what clinical decision support rules would match up with those. So when you work with us on your meaningful use report, your status, what you need help with, we don't just want to look at your meaningful use report, we also want to look at your clinical quality measure report. Some of your systems have those in the same report, many of your systems have those as separate reports, and you need to be monitoring both of those. So we did say that we would take a minute to come back to the summary of care referral because this has caused a lot of angst, if you will, among our practices in meeting this requirement. We like to say that, or I like to give the comparison, is it's as if you have a phone and you've got your own phone number, but you might not have the phone numbers of the folks you have to call, or they might not have a phone. And if they don't have a phone and a phone number, then you can't reach them. So this analogy applies to exchanging this information using direct secure messaging. You have to have the direct secure messaging tool either through your EHR or through another service, and the people the practice that you're sending to, the referral to, has to have a direct secure email address. So it's a two-way street. You have to have it, they have to have it. And some of your specialists have been very slow at adapting this. So we want to talk a little bit about what to do about that. So this requirement is a requirement for everyone. It is this summary of care. Some of your systems call it the transfer of care, or the referral document. Some call it the CCD, the continuity of care document. Some call it a CCDA. I apologize that we can't get all the EHRs to call it the same thing, but they should know what you're asking about. You have a certain workflow that you have to go through to create this referral, to put in the order to create the referral, create the summary of care document, and then that document is what you must send electronically using direct secure messaging. The denominator for this measure is all care transitions. If you have a 0 in the denominator, then and you've done referrals, this tells us that you haven't used the workflow within your system to generate this document to count for meaningful use. So that may be something that we need to work with you on if you have a 0 in the denominator. And that is specific to each EHR. The numerator is the number that you've sent out electronically. And electronic does not count faxing. So this is, the numerator counts how many you've sent out using direct secure messaging. If this doesn't make any sense to you, or you have been frustrated with this, if you'll let us know that you need some help with this, then this is something that we can focus on with your practice to see if we can help you figure out a strategy. The best strategy we have seen is if your referral providers don't use a direct secure messaging, then we can get them some assistance on getting one that's provided at no charge with the state, and then you would have to test that to make sure it was working, and then there might be some tracking issues you'd want to resolve. But we can help you work through these if you have issues, and we know that it's a struggle, and we know that it has to be done one at a time. So it is a little frustrating, and again, in a couple years, we'll be way past this. Now, for this exchange, as I said, that you have to have a direct secure email address that your EHR vendor has provided, or that you've gotten through the Georgia Health Information Network. We provide that link for you there. Right now, they are still providing direct secure email addresses at no charge to practices, And so this is a good time. We can't guarantee that that will continue. And so this is a good time to perhaps get them to help you out with getting your direct email address or your referring physician's direct email address. I would like to say that the GHIN folks can help you set up the direct email address. You might need to ask us to help you with the workflow and the process. That's not really what they're there to do, but that is something that we can help you with. You do have to understand the workflow to generate a summary of care document, which is either called a CCD, a CCDA, a transition of care document. I wish it was all called the same, but it changes from EHR to EHR. But we do find that many practices are not using the workflow that generates this as needed. So that is something your EHR vendor might be able to help you with, or you might need us to help with. You need to understand how this tracks for meaningful use. Some EHRs don't give you credit for this unless they receive a receipt from the other provider saying that it was received. This is an electronic kind of hands-off situation. Some systems just require that it's sent and it counts them. Some systems require that it's sent and a received receipt is sent back. So this will vary based on your EHR and may be something we have to look at, because we may have to help you with another method of tracking if the send receipts are not coming back to you properly. So this is going to be processed differently based on what type of each EHR you have and which direct secure email address you are using. So we can't just generically say this will work for everyone, just go do it. We usually will have to work with you on working through the workflow and then determining how your system actually tracks for this. But we can be available to help figure that out and to work with your EHR vendor to help you accomplish it. Obtaining the direct email addresses from your providers, I usually suggest to practices that they take their top 10 practices or physicians they refer to and contact them and work through the sequence of, do you have a direct email address? We refer to you. In order for us to meet meaningful use, we really need you to be able to receive these electronically, and so we need you to have a direct secure email address, either through your EHR or through GHIN. So this is a conversation you need to have with the providers that you refer to. Truly, they depend on your business and your referrals, so we would hope that they would attempt to do this just to continue to get those referrals. We have seen some practices that have quit referring to some providers because they cannot accept a direct email address. I have to tell you folks that this is a very, very critical component of MACRA and Stage 3, which we are looking at for 2017 and 2018. So I would really like for you to work on getting this resolved now before the more heavy lifting on this requirement appears in MACRA. So please, if you're having struggles with this, please let us help you or get your vendor to help you accomplish this. And also let's use those GHIN provided direct secure email addresses if we can. But again, please don't depend on them to help you with the workflow or to getting your other practices to use it. They can provide this and they can provide it for free, but they can't make your practices that you're referring to do it. So that's going to take a group effort. And quite truly, summary of care and transition of care is intended to be a group effort. It is intended to have the community of care, those providers that are working together to care for an individual patient, transmitting and exchanging information about that patient electronically and securely, and not using the fax machine, not dependent on the fax machine, but have it electronically. There is another step to this coming up next year that requires that you consume that information within your EHR, and that is another barrier that we'll have to, a hurdle that we'll have to jump over. So we really want to get this exchange part figured out now, so it won't be an issue for you when we go on to the next stages. in coming years. So when you're doing a summary of care document, the workflow is you generate it, usually using an order for a referral, and you may have a pick list, or you may have to type in the direct email address of who you're sending it to. You may have to attach the summary of care document to that email, just like you would a regular email, or your system may attach it automatically, and then you would send it to the other provider using their direct email address. And I apologize if this is confusing. We would be more than happy to talk to you individually. If you're struggling with this, would like to let you know that there are a great many practices, probably over 40%, that are still struggling with this requirement. You have time to fix it, so let's get it done. So the next thing that we wanted to make sure that we covered today was the public health and clinical data registry reporting. Before I go into that, does anybody have any specific questions or issues that we could address on the phone about your summary of care or your health information exchange requirement? If you put that in the chat line, then we will give you a few seconds to put that in the chat line and see if we can address your question. Okay, I'm not seeing that, but you can go ahead and put it in, and we can come back and make sure that we talk about that at the end of the session, because I know it's confusing. We try to make it as simple in our explanation as possible, but working with you individually might be the best solution, but let us know if you need the help. So now we're going to look at the public health and clinical data. Okay, we did get a question asking if this is required for dental practices, and if you do more than 100 referrals within the attestation period, or if you do more than 99 referrals within the attestation period, then yes, it is required for dental practices. So this may be something we want to take a look at. We do find that dental practices do have less than 100 referrals during the time period, so it would depend on what number your denominator is showing for this, as to whether this is something you're going to have to be worried about. And we'll be glad to address that individually with you. So as we look at the public health and clinical data registry reporting, this has been, probably next to HIE, this has been a huge issue for many of our practices. To meet this requirement, you have to show that you're in an active engagement with the public health agency or clinical data registry to submit electronic public health data. And for 2016, all EPs must meet 2 measures, or you have to meet 1 measure and exclude 2, or you have to be able to exclude 3 measures. So many of you got the immunization part working and thought that would suffice, but it will not. So we're going to talk about what are we going to do about this. First, we'll look at what active engagement means. And active engagement means one of 3 things, and any of these will qualify. You have to have completed a registration with that registries to submit data. And that registration should have occurred within 60 days of the start of your EHR reporting period. In other words, for those of you that are looking at a full year, calendar year of attestation, this registration should have occurred for all of your registries, I believe by March 1st. Now, I know that many of you were not aware of this requirement, or that you had the 60-day deadline occurring. So some of you may have done this after the start date or the end date. Some of you still may not have done it because you knew that you didn't have a registry that you could participate in, so you didn't do anything. But you need supporting documentation to prove your due diligence and that you tried to get a registry, and that due diligence should have been completed within the first 60 days. Now, the ONC has stated that they are going to be try to be flexible about this requirement because the 60-day requirement has been a problem. But we don't know exactly how flexible they're going to be. So my advice is, if you have not done this, then go ahead and get it done. And there's not a guarantee it will be acceptable, but we do hope that it will be accepted. If you've registered and are participating with a registry that you registered with in a previous year, you do not need to submit additional registrations for the same requirement, but you will need proof that you did that. So if you did the registration last year, then you need proof that you did that registration for this year, to show for this year. You don't have to re-register, and I'm afraid we've really bogged down the syndromic surveillance folks. I'll talk about that in a minute, because I know that I had most of my folks go ahead and register again, and you had already tried to register back in 2015. But I'm sorry to cause them that inconvenience, but at least I know our folks have their proof. A second part of engagement is testing and validation. You may be in that part of the process, and that's acceptable, or you may be in production mode, and that you're electronically submitting production data, and of course that is where we want you to be with the registries, so we just have to be able to prove that. And often a screenshot or a transmittal report will suffice for that. Again, the timing of the active engagement was supposed to have occurred within the first 60 days of the reporting period. If you had a registry that wasn't available in the first 60 days, but is now available, then you just have to have the proof that it wasn't available in those first 60 days. We do encourage you to go ahead and participate if it applies to your practice and your specialty, but if it was not available during the first 60 days and you have the documentation saying it wasn't available, that will suffice. So this is just a clip, and many of these next screens are for you to have access to go back and look at when you get a copy of the slides. And this is where CMS actually defines what you have to do for this registry reporting. And there's a link at the bottom that can take you to this if you wanted to do additional measures. But again, it's just so you'll have a copy of the document with the requirement. There are several exclusions for not meeting this requirement or for being excluded from this requirement. And we recommend that you get a copy of the FAQ that CMS has provided that applies to you, and you have a copy of that FAQ so that if you're audited, you can say, I did take an exclusion, and here's the FAQ that said I could take this exclusion. So we never know how those FAQs are going to come and go. We try to stay on top of those for you, but what we've done on these next several pages are provided you with these exact FAQ numbers so you can go look them up and get a copy of the entire FAQ to support your position. So this first FAQ states that an EP who had not planned on new active engagement registration of intent requirement, it talks about how that excuses you, but that was for your 2015. I probably should have taken these out. They don't all apply to 2016. So I'll go to the next one. And this is the FAQ that says that it says, in order that providers are not held accountable to obtain and implement new or additional systems, we will allow providers to claim an alternate exclusion for certain public health reporting measures in 2016 if they did not previously intend to report to the Stage 2 menu measure. So folks, this is the golden ticket. If it was going to cost you additional money to participate in a registry that you did not intend to participate in, the federal government has said that their intention was not to penalize providers or to make them spend more money just to meet this requirement and not to benefit their practice. So we were very glad to see this particular FAQ. And you can go in and look up the CMS FAQ 14397 and get a copy of this so that you will have this in your records, and if audited for an exemption, you can provide this FAQ as support. Again, this FAQ says that they did not intend to penalize providers requiring them to make changes to their systems or do reporting that was not necessary or had an additional cost to it. And so if that were true, you could take an exemption, and this is the FAQ that allows you to do this. This is a similar FAQ. It restates that they did not intend to inadvertently penalize providers for changes to their systems or reporting made necessary by the provisions of the final rule. So it includes exclusions for providers to measures for 2016 that might require the acquisition of additional technologies that they did not previously have or did not previously intend to include in meaningful use. What this means, folks, is if the only way you could participate in a registry was to pay your vendor $300 per provider per year to participate, and you had not planned to do this because it wasn't fundamental to your practice and it wasn't in your plans to do, then you can take an exclusion, and FAQ 14401, again, will support that exclusion. So, and you can use this for more than one exemption. So that, again, the intent was not for you to spend more money to get the technology to enable you to do this with your EHR or to pay a registry to have access to it if you had not intended to do it for your practice anyway. So I hope that I've made that clear. I do recommend you look up this FAQ if you feel it applies to you, and that you maintain a copy of this FAQ, not just the link to it, but actual print out and put the link, the URL on the document so that you can provide this if questioned for an audit. I'm sorry, I'm having a little problem getting to my arrows. Here's a third, and I'm sorry if I'm beating this up, but this has been such a problem and caused so much concern. And this was a question around how a provider has to determine if there's a specialized registry for them. And again, this is an FAQ that if you did your due diligence and there was not a registry, we recommend that you access this FAQ 13657 and you have a copy of it available if you are audited, if you use an exemption based on a registry not being available that applies to your practice. So it says in this FAQ that you are not required to make an exhaustive search of all potential registries. You just must take a few steps to meet due diligence to determine if there's a registry available for you or if you meet the exclusion. So the first is that you should check with your states to determine if there's an available specialized registry. And in a minute, I'm going to talk about syndromic surveillance and its availability to meet this measure. And then secondly, an EP should check with any specialty society with which they are affiliated to determine if the society maintains a specialized registry that you can, at which they have that has been approved as a meaningful use registry, because they could have a registry and it not be approved. So it has to be an approved registry to meet meaningful use, and they have to have made a public declaration of readiness to receive data. So you could actually cut and paste this requirement out in send it to your specialized registry and ask them if they meet this requirement. So that they know you need to know that it is a credentialed or approved specialized registry, and they they have declared readiness to receive data no later than the first day of the provider's EHR reporting period. So many of you, many have popped up recently or in the last 5 months, but they weren't available when the reporting period started. If an EP determines no registries are available, they may exclude from the measure for at least the registry that you were checking, not for all 3. So if you find that there is, for instance, pediatrics, if you contact your state pediatric organization, I believe it's the Academy of Pediatricians, then the individual there will send you an email stating that they do not have a registry. And that email serves as documentation of your due diligence. If you have a different, if you're in a different specialty or in primary care, then we need you to contact your professional organization. We recommend that even if you make the first contact via phone, that you get the responses in an email so that you have this documentation available. And if they send back to you and say, no, we don't have a registry, that is your proof. Save that document, have it available in case of an audit. If they send it back and say, we do have a registry and it's at no charge, then go ahead and register for that registry and save that. That's the first step and meets the requirement. If they say we do have this registry, but it'll cost you $500, then that requires you spending more money for a technology you had not planned to participate in, and so that could serve as your documentation for an exemption based on that earlier FAQ that said you did not have to spend more money for technology that you had not planned to use. So I'm just going to pause for a minute and see if we have any questions about that can be answered in a reasonable amount of time. Okay, we do welcome that you go ahead and put the questions in and we can circle back to them at the end. Documentation for audit purposes, I think I've already gone into this, but you have to have either documentation for having met the measure or an FAQ to support your exclusion, and you have to have a copy of any communications that you had with your specialized registry or with your professional organization saying they don't have the registry, they do, and you've registered, you've applied to participate in it, or that it's going to be a substantial cost. I will have to say that the Medicaid EHR incentive program now requires you to upload this documentation at the time of attestation. So on the Medicare side, you would have this ready for in case of an audit, either a prepayment audit or a subsequent or a later audit. But for Medicaid, you have to have this documentation and upload it at the time of your attestation, or you can't move forward. So that is different than in previous years. It was true for your 2015s that you might have just gotten through with in the last few months, but it is also true of 2016. So we encourage you to go ahead and have this ready so that when you get ready to attest from your Medicaid, you can simply upload the PDF of these documents, and they won't have to come back to you and ask you for them. So we do have 3 options for your meeting this measure, and you have to meet it with 2, or you have to meet 1 and exempt 2, or you have to exempt 3. The first is for immunization registry reporting. Most of you that are in pediatrics or primary care will have to meet this measure. It is considered an active component of practicing medicine, and so the folks at GRITS, at the Immunization Registry, are very good at working with folks to make this happen. And if you haven't done this and it's applicable to you, you need to do it. I'll talk about this just a little bit more. The second is syndromic surveillance, which I'll talk about in just a minute. And then your specialized registry which is something that your EP would be engaged in because of your specialty. So the first one we mentioned is immunization. So you have to have active engagement with the public health registry. It is a yes/no response. There are not many exclusions to this, and we will tell you that if you give flu shots or Gardasil, that counts. So there's not many reasons to exempt from the immunization registry. We have a link here that gives you the contact, lets you approach the GRITS registry and get this going if you have not already done so. They will then provide you with documents that you need to provide to your vendor, and you can get this going. You can at least register with them and begin the process, and you will qualify. So if you haven't done this, please make this happen if it applies to you. If you don't do any immunizations, then you just state that you don't do immunizations, and you need to make sure that your EHR doesn't show you doing any immunizations. What we've done here is we provide you with a look at the specifications. I'm not going to spend any time on this. You can come back and take a look at it, but your vendor will need to know this information. And again, here we have the contact information for the individuals at GRITS, and these folks are very good at working with you, and we do recommend you contact them and get the ball rolling. For your syndromic surveillance, the fact is that there is an exclusion for this if it is not available or capable of receiving from EPs or has not declared readiness to receive electronic syndromic surveillance data from EPs. And in the state of Georgia, they are not ready to receive from EPs. So you could all take this exemption. In order to get this exemption, as long as you're EPs, there's the content around this on their website, which we provided, but what you have to do is you have to actually go onto the site, and if you click that link that we showed back here, where it says click here, if you click that link and you fill out this particular document, and when you're filling it out, if you will check eligible provider and then check syndromic surveillance, then they will send you an email that says that it's not available, and that is your proof for uploading if you're testing for Medicaid, and it's your proof for an audit on the Medicare side. Very easy to do, and they send you the letter. No reason not to do this. It's very easy, and those folks have been very cooperative in making this work for us. Additional registries, again, it's active engagement to submit relevant data. So it would have to be data that was relevant to your practice and to the practice of medicine and your specialty. The same exclusions apply. It can include certified public, they have to be nationally certified public health or clinical data registries. That's what I was talking about a little bit earlier. You have to do your due diligence, where you contacted, for example, the Academy of Pediatricians and they said it wasn't available, or a specialized registry that has confirmed readiness. Again, we've outlined what you have to do. We've already discussed this, but we just want to give it to you straight off of the site of what you have to do to show your due diligence with a registry. And there is a registry for cancer that is available. If you don't track cancer or participate in the treatment of cancer, this really isn't relevant to you. So we don't want to encourage you to try to register for this if it's not relevant to your practice. We've mentioned derm, urology, hematology, medical oncology, and gastro, where this is relevant to you, and we do recommend that you participate in this registry. And on that same site where you went to for syndromic surveillance, at the same time you're checking syndromic surveillance, you can check cancer data registry and begin that process of registration. This filling out this and checking this box, doesn't confirm registration, but they will then contact you and you can get that registration begun. So, are you ready to attest? Do you have all your yes/no measures covered with documentation? And for the Medicaid attestation, you're going to have to upload that proof for all your yes/nos. Have you run your dashboard and looked at your year-to-date or your 90 days if it's your first year and made adjustments to your workflow? Have you run your clinical quality measure reports and made sure that your that your clinical decision support rules match them? So I think we had another polling question right now that was going to see how many of you felt like you still needed some assistance. I think that's the original polling question. There you go. Okay, well, that is revealing. Okay, I know that a few of you that I'm working with on an ongoing basis, but certainly not 80% of you. So if this is something, and I'm sorry if I couldn't make this any more clear, but many of these things need to be worked on an individual basis. If you do feel that you need some assistance, if you'll please put that in the Q&A portion, your email address, your name and email address, excuse me, and we will get someone to contact you. And we recommend you do that pretty quickly, folks, because times are wasting. And I see that someone has asked if there has been an announcement regarding if there's a 90-day reporting period. As of an hour ago, there has not been that announcement. There have been announcements that we have had legislators that have asked for it. We have not had the approval. We have seen a proposed rule revision for hospitals that mentions reducing to a 90-day for both hospitals and EPs, but that has not been finalized nor approved. So for right now, if you're not in your first year, we're looking at a 365-day, and I know all of us are hoping for a 90-day, but we've got to march forward as if it was 365 days. Okay, so we see that some of you have asked for assistance. I was thinking this would be a little bit more, I didn't realize everybody would see this, but we do have a helpline number here for GA-HITEC, and we have a URL where you can go to a contact us. If you're not comfortable with putting your name and email address up here for us to contact you today, please call the helpline, and Andrea and her team on the helpline will work to get you some assistance. I see a question that says, if 90 days is approved, can we still report for 365 days? In the past, you have been able to report for a longer period of time, but until we get a change rule, I can't really commit to that. So this says the reporting period is not a problem, but what are the attestation deadlines for reporting new EPs and 365 days? So that is a good question. The deadline is February 29th, 2016 for Medicare. And gee, I may need Phoebe or one of the others to help me out here, or Corliss if she's on, but I believe that you've got a little bit into March on the Medicaid side, but we can provide you with that information. But basically, you have until the regular deadline, February 29th on the Medicare side, and then I think we have until March on the Medicaid side, but we will make sure we get you an announcement for that. Here's a question, is there a link to check with your state concerning specialized registries? I'm not familiar with one for specialized registries. I know we do have connections with a service that covers lots of specialized registries, and if you want us to, we can give you that information. I don't think there's a state site other than the one that I just took you to for syndromic surveillance, cancer, and immunizations. Oh, thank you. It is 229 from oh, I knew the Medicare. I was looking for the Medicaid. Now I see someone has put up the Medicaid deadline is the 31st, and let me back up here. Your time period for attesting the data, your attestation period is through December 31st. I thought the question was when could you attest? So let me back up and make sure I'm perfectly clear on this. The deadline, your time period for attestation for a full year is January 1, 2016 to December 31st, 2016. That's your attestation period. When you can do those attestations is you have to attest by February 29th on the Medicare side, 2017, and you will only use 2016 data. Okay, we have lots of questions coming in, and I think that I don't know that I've gotten them all. Okay, so we keep getting answers for the attestation deadline from Medicaid that says 12/31/2016, and I believe that has been adjusted, and there is an extended period, so we'll get one of our folks to help provide that around the Medicaid deadline. Your attestation period is 12/31/16, but obviously if you have to track through 12/31/16, you couldn't attest unless you did it, like that night. So your attestation period is different, but the time that you can attest occurs in January and February of 2017. Your attestation period must be the year 2016, January 1 to December 31st. So, okay, I see that Corliss is giving us a message that they've requested an extension but have not received approval. So we will follow back up with you on that one because that is a little different than the information that I had received. So folks, we'll give you some clarity. Oh, that's 2015, Corliss. Thank you so much. Because that's payment year 2015. Corliss, thank you. I was focused on payment year 2016. So that's answering a different question, and I don't even want to go there because it implies that there might be some relief for you that missed the deadline, and we're not going to discuss that today for 2015. So for 2016, I think we'll make sure that we get you an update on those deadlines. But it is for the full calendar year, and then for Medicare, you have until February 29th to 2017 to put in the data that you collected from 2016. And then this question around new providers. This is if you have a new provider and you don't want to fill out additional paperwork. If you don't mind, I think the best thing is maybe to put together a policy sheet to distribute to all of you with these deadlines listed. We actually had a slide on it and we took the slide out. So we apologize for that. And we'll get you the information on the attestation deadline for new providers for Medicare and Medicaid. Because the October 1st deadline is a little different. So if you will bear with us, we'll get you some information on your new provider deadline for Medicare and then getting into the system. So if you'll hang tight for us for that, give us a couple days and we'll get you the result of that. I will say, if you have met the measures, go ahead and attest. If you were working towards an October 1st deadline, let's go ahead and do that. But we will get you the parameters around the latest release of the dates for each program and the program year and when they apply. So we do have some work to do for deadlines. I'm sorry that I took the slide out and couldn't go back in and recapture the slide that went over each of these, but we will go back and get that slide and map this out and send this out to you folks so that you will have what the deadlines are. And And I think it's Sue Lee. If you want some additional assistance, if you'll put your contact information in there, we will follow up with you individually. And I see we have one more person. It won't know if the slides will be sent out. And I cannot answer that question. I believe they're made available. Oh, there you go. You go and access them on the website. So that appears to me that we won't be sending them out. If you will go to this site and click on that link, you will have access to these slides. And we got one more person typing in. I know we're out of time. We've got one more person typing in.
Okay.
And I think